Hypophosphatasia was first recognized as a distinct inheritable entity by Rathbun in 1948. We find that in our very young patients, within the very first few years of life, sometimes there are very severe manifestations of this deficiency of alkaline phosphatase. In about 60 to 70% of the patients, we could find that if it's manifest at birth, we'll find that about 60 or 70% will die in early infancy. Those who survive, we find that they have marked ricket-like deformities of the extremities. The calvaria may fail to calcify. They'll have dyspnea, cyanosis, vomiting, constipation, and renal calcinosis. We find sometimes that at onset of the symptoms in early infancy, during the first 6 months of life, these patients will develop a rachitic rosary. They also can have enlargement of the long ends of, rather the ends of the long bones, just like in classical rickets. Characteristically, in addition to the deficiency of the enzyme alkaline phosphatase, there is a interesting biochemical aspect of the disorder, in which there is an excretion of ethanolamine phosphate in the urine. Ethanolamine phosphate is found in the urine of patients with hypophosphatasia, celiac disease, and hypothyroidism, and also scurvy. But only is it very rarely ever found in so-called normal persons. If ethanolamine phosphate is not excreted by either a parent of an affected individual, it's not at all uncommon to find this present in the urine of an aunt or an uncle of one of our affected children. Apparently, patients with this manifestation apparently are homozygous for a very rare recessive gene. These patients have the very large pulp chambers. The teeth are hypoplastic. We find that these patients will have a loosening and a premature loss of their teeth, such as in this youngster. We find that his chief complaint actually was that he came in seeking attention because he could not run up the steps, keep up with the other children because of his skeletal deformity, and the fact that we find that in this youngster that in his teeth he was only 7.5 years of age, but he already had lost most of his dentition, beginning at, I'm speaking of the deciduous dentition, at 18 months of age. He still retained 4 deciduous teeth. The deciduous second molars were present, and we find that anytime that we have a premature exfoliation of teeth, we should, that is in childhood, we should consider in the differential diagnosis acrodynia, keratosis of the palm and the feet, like in Papillon-Lefevre syndrome, the reticuloendotheliosis, and also in hypophosphatasia. In these preceding cases, we see the exfoliation of the teeth for reasons other than root resorption. In hypophosphatasia, the most characteristic finding is the spontaneous shedding of the teeth. It's not at all uncommon to sometimes be able to reach into these patients' mouths and literally lift out a tooth, which the deciduous roots have undergone no resorption whatsoever, and we can just literally just pick these teeth right out of the mouth. Through the studies in cooperation with several pedodontists in Corpus Christi, Dr. Wheatcroft and Dr. Quentin Williams have been able to follow a family in Corpus with hypophosphatasia, in which 3 of the 7 children are affected. The mother has been able to diagnose each of her affected children by observing that the deciduous teeth are lost by 18 months of age. She stated that if in any instance where her children still had all of their deciduous teeth by 20 months of age, she knew that that child wasn't affected. Certainly we can observe the knock knee, the defective gait. Some of these children may be delayed in walking and being able to stand, but most characteristically, where we have this observable sign of loosening and premature loss of the teeth is pathognomonic of this syndrome. Apparently the deciduous incisors are the teeth that are most often involved, and it may be that the fact that some of these deciduous molars stay in is because they're multi-rooted and they're somewhat more stable. But the anterior teeth, as we see in this child, it was born in April 1963. By 1966, she has lost most of the deciduous anterior teeth by 4 years of age. Now, this child may have a premature eruption of the permanent dentition. Her sister, we observed, again by 4 years of age, she also has lost her deciduous mandibular incisor teeth, and she apparently was losing the maxillary anterior teeth at a normal age of about 6 years of age, though. And we observed the other sibling, affected sibling in this series, that this youngster was born in December of 1961. He still had some of his deciduous teeth a little over 2.5 years later, but by 4 years of age, he was sloughing all of the deciduous anterior dentition. It's been described by Bruckner and his associates that the premature loss of the deciduous teeth and occasionally of the permanent dentition is a result of poorly formed enamel, poorly formed cementum. In fact, they report an acementogenesis. In fact, there is no cementum whatsoever present on the roots of the teeth. This is one of our specimen incisors' teeth. That there's just a basophilic staining material present, numerous clumps of bacteria. There is total absence of cementum on the roots of these teeth. Apparently then in hypophosphatasia, because of the lack of cellular cementum on the roots of these teeth are prematurely exfoliated and lost. We have observed the lack of acellular cementum on the roots of teeth in cleidocranial dysostosis, but we know that these teeth also are not lost prematurely. So there seems to be possible controversy present, whether or not presence or absence of cementum. The fact that we cannot normally have the attachment of the periodontal membrane fibers into the cementum as in normal teeth. This may be a contributing factor to the premature loss of these teeth. Very definitely now that we must include in our differential diagnosis of the premature exfoliation of these teeth. We've mentioned acrodynia, Papillon-Lefevre syndrome, the reticuloendotheliosis, and now hypophosphatasia. We find that these patients may have somewhat large pulp chambers, but these certainly are not on the order of what we have observed in vitamin D resistant rickets. We do have the similar skeletal deformities, but classically there is very low serum alkaline phosphatase values in this syndrome. The serum alkaline phosphatase is markedly lowered, as is the tissue alkaline phosphatase. How these patients are able to, their osteoblastic activity is continued to be able to function is certainly is one of the ignomos of this condition. We do know that those that are more severely affected seldom survive infancy.